Very good morning, everyone. So I'll be presenting three cases which were little dicey, and the presentation made us think that are we really on the track when we are treating them. I would like to ask questions to the panel in between my cases to understand the complexity, because many of them have not reached the conclusion yet. So this is the case 1. A 70-year-old female presented with the redness and photophobia, which is since 2 months, for which she was taking treatment from multiple doctors, and her vision best corrected was 666/36 with the grade 2 cataract. These are her clinical pictures, and if you see closely, this may not be very appreciable, but she had a palpable hard mass, almost 1.5 centimeter here in the lower pharyngeal conjunctiva and the lower lid. We had our own differential diagnosis that it could be blepharoconjunctivitis or a severe conjunctivitis, and there was a discharge as well, and the pituitary sebaceous gland carcinoma, which has been discussed. But patient was already taking antibiotic and the steroid topical combination from almost last 4 to 6 weeks, and there was no resolution of congestion, neither the part of the pain and the discomfort. So of course we went ahead with the biopsy. We did a map biopsy as well to understand what is it, and the histopathology confirmed it's an inflammatory lesion, which we did not believe primarily. We repeated the histopathology, and again it was an inflammatory lesion. Patient was treated with the oral steroids, and the whole course was settled down there itself, and the mass completely disappeared. So the take-home point here is a patient might present with certain mass which primarily could look a neoplastic, but doing an incision biopsy always helps, and doing a map biopsy is not a harm if you are suspecting anything which can have a distant spread than the lesion being seen. The next case is a 25-year-old female. She presented with the drooping of the eyelid. Since 2 months, there was no history of trauma, and the vision was fine. There was very mild ptosis, but since there was only 2 month history, we decided to go ahead with all the workup, including myasthenia workup, and everything was negative, including the neostigmine test. Finally, on the demand of the patient, we decided to go ahead with the surgery, and patient was all good after 15 days. She was fine till 3 to 4 months. After that, she again started complaining there is some amount of drooping with which she was not happy. And again we did the workup, everything was fine, and the lateral drooping slowly started increasing, and then we had to operate her again just to give her a cosmetic result, which again sustained for a period of time, but later on again it started drooping further. So I'd like to ask panel here that it's a unilateral ptosis, and despite of the uneventful surgery, there is constant drooping. There is no blepharochalasis history or anything. So where are we going wrong, or what further we should do in this case? Dr. Leone, please.
Phenylephrine test?
Yes, sir, it was negative.
Negative?
Yeah.
Yes, in this case, I think even if you do a posterior approach and you resect the Miller's muscle, they get better.
The posterior approach in the second surgery you were suggesting?
You can do it even at the second time when you do it anteriorly. Then you can separate the aponeurosis from the malar muscle. You advance the levator muscle anteriorly, doing, a double layer. So you separate both aponeurosis and malar muscle from the conjunctiva. If you are more familiar with the anterior approach, they usually get better. Probably she has a very strong right dominant eye, and so you have to overcorrect ptosis on the table a little bit more.
The overcorrection in the posterior approach is the way to go. That's what you are saying, correct?
No, I say you can either choose the posterior approach and that's it, and you see how it works. If you're more familiar with the anterior approach and you have a drooping of the eyelid following primary surgery, then you advance both Miller's muscle and aponeurosis from the anterior approach, but you have to overcorrect on the table at least 2 to 3 millimeters. Probably these cases happen when you have a very strong right dominant eye in this case.
Correct.
You see, so ptosis is worse than you see.
Okay.
You know what I mean? You have to overcorrect it because it tends to do a
Got it, to get the correction. Mukesh sir, since you had a talk on posterior surgeries, what is your experience with recorrection of your anterior approach with the posterior approach when there is a recurrence with the mild ptosis?
Well, it's functional, okay, fine. So I'll answer, I think, both comment on the first question also. If you are doing a skin approach, what kind of suture are you using for levator?
Sir, Proline, 60 Proline.
For levator, then it is fine actually. Sometimes we use Vicryl for levator, and in some of the patients, the healing of levator is not proper and Vicryl get dissolved. So if you are using non-absorbable, then that point goes away. So fine, coming to your question of resurgery with posterior approach, see, it depends who has done first surgery. If an accomplished oculoplasty surgeon has done first surgery, then we can think of doing resurgery because the adhesions would not be that much and resurgery will not be that problematic. But if first surgery is done by a novice, then sometimes the adhesions are too much to do proper, to get proper result in resurgery through posterior approach. But with MMCR, even if you are not able to dissect it properly and you are able to resect out the tissue with some fibers of levator with adhesions, results would be all right. But you'll have to check for fibrosis initially by injecting something subconjunctivally. If fibrosis is too much, things are bad, then go from anterior.
Good morning. I have an observation on your case, Dr. Sumeet. I am Dr. Abjeet. Did we try and look at the position of the right upper lid in the first time before you operated? It seemed to be a little more retracted rather than the ptosis of the left side. Secondly, the left eye has more inferior scleral show as compared to the right eye. So are we actually dealing with true ptosis?
So ma'am, basically we had done the orthoptic evaluation as well with our...
Did you look at her thyroid levels?
They were normal, ma'am. Thyroid and
her anti-TPOs,
antibodies were
diffusion-weighted imaging of her muscles.
That was not done, ma'am.
I think we need to have a keener look at this patient because it doesn't seem to be just a plain simple case of left upper lid ptosis.
Okay.
That's my opinion.
Fine.
Hi, I'm Dr. Ruchi Goel, and actually I had the same concerns. I would not have operated like just 2 months history. I would have gone and done a more comprehensive workup for the patient first. And why do you think first, why did she develop the ptosis at all? One was, of course, because of the Hering's law, you had some kind of a picture which was not really a 2 millimeter ptosis. The retraction, in fact, if you go back to your previous picture and you can see there is some kind of a disproportion. So maybe we were not on the right track when we thought of doing a ptosis surgery in the first go. So whether it fails or it does not fail, that is a second question altogether. And did you evert the lid? Were there any other signs? Why did she develop an epineuritic ptosis? I think you suppose that it was an epineuritic ptosis. That's why you went ahead and did this.
Correct.
So what could you find the cause of epineuritic?
I could not find the cause, ma'am. That's why my primary diagnosis was myasthenia, then the aponeurotic. But since everything was negative and she never used contact lenses, no allergy, no rubbing, we could not find the cause.
So maybe I think the best course would have been to observe and do a better workup and then go ahead and do the surgery.
Okay, fine. Feroz ma'am, do you have a, can
I think we are done.
Okay, ma'am, I'll stop.
Sumeet, nice case.
Fine.
Thank you so much. Regarding your first case, like the granulomatous lesion in the lower eyelid, we can have very bad MGD presenting like that. In fact, I had a patient similar case. We did an incision biopsy. He came with a lymph node also where there was so much of a suspicion of a malignancy. It came out to be a tuberculous granuloma, TB granuloma of the lower lid. So granulomatous lesion can also present like that. So as you rightly said, incision biopsy is definitely important because if you go for an excision where there is question mark, it's going to be a large excision without an evidence. Thank you so much.
Thank you, ma'am.
Similar to in your first case, I had a patient where actually there was fungal infection of the sinuses that presented in a manner, So, but you did the biopsy that can pick up both the things.
So I recently had a case that looked completely like carcinoma, if you see per se, loss of lashes, nodular lesions, but she turned out to be lupus.
Oh.
On all 4 eyelids she had it. That was one reason to not suspect malignancy as the primary diagnosis. So we went ahead with an incision biopsy. It turned out to be lupus.
Yeah. I think one important finding may be the widening of lash margin. In malignancy, the margin got widened up. Orifice of meibomian gland and eyelashes, that distance increases typically. And if we are dealing with the pagetoid kind of spread where there is no nodule and there is confusion with blepharitis, but in inflammatory, you don't get that typical widening of margin. In your case also, it was not there.
Correct.
So I think that is one clinching point.
Thank you so much. With this, we come to the conclusion of the eyelid session of the oculoplasty module. Thank you so much, Dr. Neha, for moderating, Dr. Sharma, Dr. Chandana, Dr.